Everyone, it's my privilege to introduce Frank Ruschitzka. You all know Frank Ruschitzka. He is heading the heart failure service in Zurich, but more importantly, he is the president of the Heart Failure Association of the European Society of Cardiology since May of this year, and there's no other person who could better introduce the new heart failure guidelines than Frank. Frank, go ahead, please.
Thanks, Philip. Thanks, Thomas, for these very kind words, and for thanks to the organizers for putting me on the hot spot for the hot topics, to setting the stage first for a superstar, Francois, and then for a legend, Mark Pfeffer. So I feel already dwarfed before I started. But that comes a bit from my psychotherapy I had the last 25 years being a heart failure doctor. When I started as a heart failure doctor, I was nobody. Now I'm still nobody, but the field has grown bigger and bigger. When you remember, I came, correct me, that was in Lugano 20 years ago, probably my first meeting I had, and there was heart failure. I was always, with my background, I felt this is the place I want to be. That was small, and fair enough, we had nothing. We had a bit diuretics, ACE inhibitors, thanks to Mark. Is he already here? They have just come to the clinics. Beta blockers were coming around the corner, and we had nothing. Heart failure is actually, at the end of the day, the price we pay for the success of cardiology. When patients die, sudden cardiac, we don't see them with heart failure. If we get them out of the acute coronary or whatever and stabilize them, we don't cure them, we make them a bit better. So at the end, it's not surprising, the better we get, the more survive, we don't heal them, they become chronically ill. Think that HIV, think that oncology gone wrong. And that's what we are, chronic disease doctors in heart failure. If you, in cardiology, if you just like bifurcation stenting and don't see the patient around it, without any criticism, then you're not the right guy for heart failure. But if you want to treat them on the long trajectory and want to impact on the life's trajectory of a patient, well, then you are our guy. So it's becoming a bit more sexy. It was a dead thing 20 years ago, but now the young guys, we had a session this morning, there were 75 people in the room, it's overflow, the young heart failure doctors. We have a new specialty, and they come and they like it, because they are smarter than us, because they see there's a lot of patients. And I brought you here some numbers before I get into the guidelines, is, heart failure, the prevalence is coming up from what I saw. I told you before, but it's thanks also, half of them are ischemics. And the way we treat them acutely pays off in having them longer around us for a couple of years. So the prevalence of heart failure is going up. With Thomas and Philip and us in our group, in the heart failure group in the Swiss Society, we're always asking ourselves, what's the true prevalence of heart failure in our country? And Thomas, we don't know. We know in some parts in the world, in the US it's 2.6%. In Italy it's around 2%, in Germany it's 2.2%. We thought we are closer to Italy than to the US. If we have a conservative estimate, we have 175,000 patients of heart failure. And if you look at the New York Heart class, New York Heart 1 being asymptomatic, and 2 or 3, this is a rough estimate. We don't have the true data. But we can talk about patients who are symptomatic. These are more than 120,000 patients. So here's one misnomer. If you think New York Heart 2, Jojo, is like Hodgkin 2, then you're worse with New York Heart 2. They have half of them are dead after 5 years. So New York Heart 2 is symptomatic, they suffer, and it's by no means moderate heart failure. It's severe disease with a little bit less symptoms than New York Heart 3 and 4. Keep that in mind the way I want to set the stage for my talk. And here comes the legend, Mark. Actually, I'm here talking about guidelines, and I just, the intro, I was waiting to look for you. There would be no guidelines with you because we would have no drugs to talk about. So heart failure is a big player now. So it's not only prevalent, it's also damn costly because it's the most common reason for hospitalization in our country. This is a Swedish registry. In the US, you can sell that as a Swiss study because they can't make the difference between Sweden and Switzerland. It's not the last joke I make about the US, Mark. You know that. You come here all the time, and you can take it. You dish out a lot as well. You can take it. So heart failure is the number one reason for hospitalization. It matters. And our cost payer, in our insurances in our hospitals, they matter about that, much more about the suffering that is associated with the disease in our patients. And the mortality is as bad as most of the cancers, you know that. And it was thanks to the pioneering work, and it was really timing is everything, Mark, that you just came in. It was Mark's breakthrough moonshot discovery that he found that ACE inhibitors provide benefit in medicine. That's, this is one of your many legacies, but we, in the late 80s, thanks to your work and Carl Swedberg's and others, we learned that dishing out an ACE inhibitor to a heart failure patients not only makes them feel better, but also make them live longer. This was the success of ACE inhibition. And then we had other crazy ideas which came to fruition. Beta blockers, which was once a contraindication, and then MRAs, mineralocorticoid receptor antagonists, that stepwise reduce mortality. And that is why we have the guidelines, because without 8 life-saving therapies to offer, and Mark helped me, ACE inhibitors, beta blockers, MRAs, LCZ, ICD, CRT, and I, as an advanced heart failure transplant guy, take the liberty to include VADs and transplant to them. It's 8. You name me any other specialty offering 8 life-saving therapies. And if we want to learn, and we will have to learn from the oncologist, want to also add the symptom-improving therapies, which are very important. If you have dyspnea 25 times, breathe 25 times a minute, you want to have a drug that improves your symptoms. You trade that for any mortality benefit. So we have a lot to offer. So if you have a lot to offer, it's complex. That's good. So you need guidance. That's why we wrote the guidelines. We write them every 4 years. And so with the diagnosis, we didn't change that much. We had the assessment of the probability, of course. You don't want to do a BNP testing in everybody. You can argue about that, but we have to be cost effective. It's a Roche product. If they dish it out for free, we do it even more. But we have to also work on our clinical skills. We didn't change the NT-proBNP cutoffs. And NT-proBNP we have to emphasize because with the arrival of LCZ, which interferes with BNP, it's probably NT-proBNP, which is clear the ship has sailed, that which we should give the preference among the natriuretic peptides for the time being. And if one is present, the NT-proBNP is elevated. We didn't cut the cutoffs in the guidelines. You go to echocardiography. Well, that's no overdiagnosis. We do a lot of wrong things in cardiology, but I think we still do underdiagnose heart failure, particularly heart failure with preserved ejection fraction. So, and for that, we do need. It's not easy. We have a joint session, Mark, here with the pneumologists. We do need to differentiate from it as a rule out the BNP, but we need the echo as well. And we need a good clinical doctor. Heart failure doctors are usually good clinical doctors. So I'm glad my echoes are running here. But the new guidelines come up with a new baby. You may like it. I know Mark has his view on it. I like it because actually I came up with a name, and you can blame me for that one. But we identified a new middle child in cardiology in heart failure. We all will agree, those of us, and we all do echo, if you have an ejection fraction below 40, well, that's reduced. A normal ejection fraction, 55, 50, we would say. But that gray zone in between 40, 50, we had to give a new name. We said, well, this is a gray zone. But when we were discussing, shall we call it HfpEF, as Scott Solomon said, I voted for MREF. I tell you why. Because I wanted to make clear that this is clearly a reduced ejection fraction. If we had named it just MEF, it would have implied it would be somewhat a benign disease. It's not. It is clearly reduced. An ejection fraction of 43 is reduced. It's not somewhere mid-range normal. It's reduced. So we can talk about that. And we also want to spur science into it, that we clearly identify that those HfrEF trials, heart failure with reduced ejection fraction, were patients usually way below 35, some below 40. And HfpEF is usually what I think truly preserved. Systolic function is actually above 50. But one day we have to move away from ejection fraction, which is a pretty lousy parameter. But it's as good as it gets. Most trials were based on it at the time. So this is the new thing you would like to take home from the diagnostics and the classifications. We have a new middle child, the HfmREF, not Mr. F, but HfmREF. Okay, you can like it or not, but I think it's clear, it's more pristine and precise to clearly call it what it is, that below 40 is HfrEF and nothing else. HfrEF, how do we treat that? The problem in heart failure is we know not that much about the left ventricle, a little bit. We only know something about insystole, not much about diastole. But the other chambers and atria, we know nothing about. Nothing about the left atrium, not about the RV and the RA. They are very important. The LA is the new frontier, which you have to work. The electrophysiologists don't like that we are interested in them. But AFib has a cause. The most important question we always teach our residents is why? If you have AFib, there's a reason why the LA is big. And what is that? These are high filling pressures. And why are they high? Well, you can call it heart failure. I think I want to rename AFib left atrial disease, but that's for the next guidelines in 4 years. But the patient with symptomatic HfrEF, we came out with a new algorithm. That looks complicated. Well, thanks to Mark it is. If we had no drugs or no devices, there would be nothing. Well, thank God it's complicated. So let's go through this a bit. So you have to have a patient diagnosed. We talked about that. And you have a HfrEF, that's ejection fraction below 40. If he's still symptomatic, after an ACE and a beta blocker, that's what you know, for what we're doing for 20 to 25 years now, add an MRA, a pleuronine or spironolactone based on this study. So we gave in the guidelines a clear 1A recommendation for these 3 drugs. Well, that is nothing new. You know that. So what's new now? So if patients still remain symptomatic after 3 drugs, here is the news. We included a new drug, which is called LZZ, valsartan/sacubitril, the combo, the ARNI, the angiotensin receptor blocker, neprilysin inhibitor, ARNI. Okay, good. Like it better than Donald. ARNI is good. So, but ARNI is the new one in there. We put on the same level what is now it's European Championship, Mark. We have football is playing. This is not the Brazil tricot, but this is, we put in CRT. Green is 1A, and CRT, depend on QRS width, and I'll come to that in a second, it's a 2A. You see up in the corner, 1A, 1 and a 2A up here. This is why the different colors. Some people ask me, why is it green, why is it yellow? 1A is green, and yellow is 2A. And that was for QRS with a relatively narrower QRS in CRT and for ivabradine. But ARNI's got a 1B recommendation. What is ARNI? Well, this is you knew it from the old days, omapatcholat. That was an ACE and a NEP inhibitor. NEP is a very promiscuous enzyme that blocks the degradation of most of vasoactive compounds there are, vasoconstrictors and vasodilators alike. I had my hands on sacubitril and the NEP inhibitors in the early days of my career with many of my friends here, with Christian Matters and others. I never really fully understood them, and I was fooled by omapatcholat, which I was very reasonably excited at that time about. But then Novartis said, because omapatcholat, which was a NEP and an ACE inhibitor, had angioedema problems, so why don't we replace the ACE inhibitor with a valsartan? I'm not crazy, as you guys know, about valsartan. Mark doesn't like it when I say that, but I have my point there, I think. But then combining it with in LZZ with sacubitril, with that NEP inhibitor, turned out to be the big slam dunk winner in the Paradigm HF trial. which reduced mortality big time. There's so many zeros behind the comma, I can't even count. These are 7. Was a huge success. In oncology, that would have been hailed as a breakthrough, kind of a really moonshot kind of discovery. And for me, I really am excited about this drug, but when I'm excited, I'm still a skeptic. I'm reasonably optimistic. We as a guideline, we decided we cannot put that above all and everything, because all of us, we don't have experience with it yet. There's still an angioedema risk with it a little bit. And guys, let's be reasonable, stepwise. Patient needs an ACE inhibitor, a beta blocker, an MRA. If he's still symptomatic, we replace it. And then we get a feel, and when they do more studies, we reconvene and put it at the front of it. So valsartan sacubitril is a drug that is contraindicated in those who have a known history of being, particularly allergic and having developed angioedema in the past on ACE inhibitors and others. I have some of these patients, not all of them. And you should go low and start slow. There's a lot of valsartan in it, 50 and 100 in the drugs. So if patients are very hypotensive, be careful. This is a drug, to cut a long story short, for those who are in New York Heart 2 and 3 and relatively stable, and thanks to the drug, they will be stable for another year and a half, which is great. But it's not for the acute heart failure patient. You kick him out of bed when he is in need in Intermax level 2 or 1. Okay, this is what we do. So we, in the guidelines, took a 1B approach. You see that in the middle. The diuretics, thanks to Professor Braunwald's dose trial, finally the diuretics got a study. Of course, you have symptomatic relief. We gave it a 1B. And ivabradine, well, you can talk about that. They, in SHIFT trial, had a reduction of heart failure hospitalization. We thought appropriately to place it next to it, but give it a yellow color as a 2AB drug. And then there are some other drugs which we don't use as much anymore, namely digoxin. For those of you who still use it, it's a 2BBB. You can talk about the AFib at one point later. Hydralazine and isobutadinetrate is very popular in African Americans, in particular in other parts outside of Europe, and there is a 2AB. We rarely use it actually in our clinics. Plus, please note the ARBs are not a first-line drug. We always use ACE inhibitor first. When the ACE inhibitor is not tolerated, we switch to an ARB. We can talk at one point whether we would start with a sacubitril valsartan combo at the beginning or not. So this is how the algorithm looks like. ACEs, beta blocker MRAs, still symptomatic, you go to ARNIs. Or, if indicated, for a device. This is a sea change. When we started heart failure, we were drug doctors. But take that chip out of your head that we are just drug doctors. We are drug devices. We are the horizontal specialty in cardiology. We combine them massively. That's why the young guys like it. So CRT is a good lesson, how we have to fine-tune and sharpen our senses with regard to how we deal with devices. There's no such thing in life, and there's no such thing in medicine, in particular in cardiology, as an unmitigated good. Not everything is good in everybody. So CRT is good in many, but not in those which we painfully showed in our ECHO-CRT trial. You know our New England paper, the ECHO-CRT trial, in patients with narrow QRS. That's not going to help you there. We have now, with sub-studies we will show you in Rome, a fantastic new algorithm where actually we'll identify those who even in narrow QRS will probably benefit, but the majority, when you just look at the ECG, no benefit. And in CARE-HF, the mean QRS was 160. So the evidence is, the sweet spot for CRT is somewhere in between. This is a wonderful meta-analysis by my friend John Cleland, with whom I wrote the device part on the guidelines with Cecilia Linder. There's the 3 of them. And and when you look at them, this is plotted QRS duration versus the hazard ratio with regard to benefit or detriment of CRT therapy. When you look at that, we clearly showed you with ECHO-CRT, below 130, there's no benefit. It's a 3A. The above 150, the mean QRS in CARE-HF was 160, don't forget that. Above 150, we all think, slam dunk. Typical left bundle, clear. And then again, as like in HFrEF, we had a gray zone. What are we going to do with this 130 to 150? We don't really know. I don't really know. Hans, what do you do in St. Gallen? It's not easy. It's not that 134 is a clear 1A for me. We have to identify and really look at that a bit and dig a bit deeper. We had still put in that those with a typical left bundle branch block morphology have a 1B in that gray zone, and with a more non-LBB morphology, and that's not only, as we know, the right bundle, it's a 2B. Well, quite honestly, that's just based on my good friend Scott Solomon's MeditCRT database. All the other CRT trials didn't show that, but we, as a heart failure community, are loyal ESC people and didn't change it as much. If you want to make it very easy, we would have taken the whole morphology thing out. But that's up to debate for future guidelines. The ICD, we didn't change much. The 2BC is for the wearable ICDs. That is the vest that you now can get to bridge those patients who have not fulfilled yet the indication for ICD. But we didn't change much on that for the ICD in particular. So, and when you look at other recommendations we dished out there, I already mentioned to you the hydralazine and isotonable nitrate, the digoxin, and the PUFA got a 2BB. There was actually a study. The PI actually died in the meantime, but unfortunately, but there was suggested some benefit, but we couldn't really give a strong recommendation for that. There are other drugs that are not recommended at all. These are the glidazones. In diabetes, and Mark, as usually is spearheading this field, we are undergoing and seeing a revolution at the moment. A lot of the new drugs coming, actually yesterday the LEADER trial was published in the New England Journal of Medicine, we see for the first time these diabetologists are not only glucose cosmeticians or the diabeticians anymore, they actually save lives. But the problem of most of these drugs in diabetes is what? Heart failure. Why? Insulin, the old guys know that, insulin is a drug, is a hormone that is antinatriuretic. If you're antinatriuretic, you retain water. That's not a good thing in a 75-year-old with HfpEF. You tip her over the edge and she can decompensate it. Okay, and don't add an ARB to an ACE inhibitors. Heart failure is not a disease. Heart failure is hundreds of diseases. We are really not. In 30 years, they will laugh about what we are doing today. The pharmacogenomics in heart failure are in its infancies. But heart failure is dominated, particularly in HFpEF, by its comorbidities. So it makes a hell of a sense that we think about it. In diabetes, we actually, not knowing empagliflozin and the new data out there yet, we took the stance to recommend metformin as first-line treatment for the time being. That's going to be changed soon. But with the time we did that, this is how we start and makes sense. Take all this crap out of the lactate acidosis. Be careful. Don't be too overly anxious with metformin. Do it. That's fine. Treat hypertension when necessary. That's good. The thiazide diuretic, the wording is not good because I'm more for the thiazide-like drugs, which are indapamide and chlorthalidone. I'm not about the Luther drug hydrochlorothiazide, which I try to avoid at all. And iron deficiency has some symptom benefit. I was involved in some of these trials, and we got a 2A. So there are other drugs that are not recommended, as I mentioned, but also devices. As we in EchoCRT showed that not all devices are good in everybody, that's the same also true, surprisingly, in sleep apnea. A device, if you've learned from the SERVE-HF trial, where you reduce chain stroke, you thought you reduce chain stroke, you would live longer and better. What happened was actually it didn't turn out to be beneficial. They did worse. It almost killed you, this little innocent sleep apnea device, the servo ventilation automatic device. Most of the patients loved it. And actually, when Martin Coe called them and said, stop this, they said, oh, no, I felt so much better, I slept better. But teaches us a very important lesson that in device trials, and that's also important out of heart failure, I'm talking about MitraClip and all that stuff, we have to rigorously, prospectively challenge them in randomized clinical trials. Because what you think intuitively is a good thing is not necessarily what you can show in a long-term trial. So coming to an end, HfpEF and MREF is still a mystery. We do not have good data outside of truly reduced ejection fractions below 40. In those from 40 to 50 and 50 and above, well, what do we have? We have give diuretics and treat comorbidities when appropriate. So that's what we do. And we should also then go for monitoring and exercise and multidisciplinary care. You see there the device-based sensing. Here there's a CardioMEMS device up there in the corner. Then you have some ICD-CRT-based devices that could give you some idea whether monitoring, Big Brother-like, watching your patient at home gives you an impact on what to do or not to do. So we felt like that we give it 2BB. They complained we should have given more, but we as a guideline committee are usually a very conservative bunch. In aerobic exercise, we felt with regarding not to mortality, but to improving symptoms, we can clearly go for a 1A. The last 4 slides I have is the new frontier, which is acute heart failure. You see, heart failure is on its trajectory, is all determined particularly by its acute decompensation. That is with any chronic disease. It's the same in HIV and oncology. But these acute bouts of decompensation, how do we deal with that? First of all, we have to teach our people, our residents, that's important. When they call at night ACS, they run. They have in their brain that chip is say, oh, we have to save the myocardium. With acute heart failure, they say, give a diuretic, I'll come in 3 hours. That's wrong. We have to also teach them the skills that you look at hyperperfusion and congestions with the classical Lynn Warren-Stevenson algorithm, warm and dry, perfused or wet or dry, and that gives you a good idea who is at risk and who is not. The worst are those patients who are not perfused and who are, of course, wet. So cold and wet is at very high risk, and that you can easily do. But we should teach basic clinical skills in cardiology still, and we heart failure doctors can deliver this. So the acute heart failure is that we look at the patient, identify the patient at risk, particularly the wet patient, and particularly those who is not adequately perfused, and then we can think about what we can give them. We can actually have not much. Acute heart failure is a Bermuda Triangle of clinical trials in cardiology. Everything that flew in and never got out, except the diuretics and maybe some nitrates. And so if the patient has a high blood pressure or relatively high, you can fool around with vasodilators. We are doing a trial, as you know, the TRUE-HF trial, which will be published at ESC. And others, and Novartis is doing the Relaxin trial, the Relax-HF trial, which will come, where it shows patients with who are wet and with high blood pressure, whether that we can do something. What we can do with inotropes, well, nobody knows. We use a lot of levosimendan. We don't really have good data in Europe, although we use it like water in our clinic. And I like it too, because consider in life the alternatives. If you have nothing else to offer, what are you going to do? Sit there and see your patient die? You will, of course, start an inotrope. But you shouldn't give an inotrope to those, and that's the guideline clear, 3A, who don't have low blood pressure and are not in need for that. Note, and coming to an end, that the assist devices, we downgraded. And for one reason, the old guidelines made a mistake. We gave for the bridge to transplant in the old guidelines a 1B, but they had never done a trial. So truly, the data we have is for destination, and that was 2A-B, one trial. And for the VAD, the LVAD as a bridge to transplant, we extrapolated some of the data and gave an expert recommendation to AC. So I'm coming to an end with the gaps in evidence. There's still a lot to learn. The new guidelines, which we'll start writing actually from next year on, we have to still learn a lot about ICDs, about QRS morphology in CRT. I want to know more about AFib ablation. And the future is not happy for those working with us. We are very happy people. We love to work with others. But for example, AFib ablation, I think we as doctors have to, as heart failure doctors, have to have a say in whether a 60 LA in an 85-year-old patient should be ablated and you do crisscross whatever ablation in them, or whether you're not. There are trials ongoing that by the time we have the next guidelines, whether in patients with heart failure in big LA size, it's really important to also ablate it, because we know all the rhythm and rate control trials out there. This is a key thing for the next years. What we didn't put in was a stitch trial, because it was just published at the time we had the guidelines present. The stitch trial was a revascularization, which showed that after long-term follow-up in patients with ischemic cardiomyopathy, the CABG provides a long-term benefit. Whether that holds true also for multi-vessel PCI, well, God knows. We don't know. Deserves a trial. And this is the stuff that's coming. There are some wonderful VAD trials by my friend Mandip Mehra from your institution coming that will finally give us the VAD indications, hopefully for a 1A in destination. And even he has a BTT part of that. It's a multifactorial, beautiful trial. So with that, I gave you a little bit of an overview. I think it's an exciting field. We are standing on the shoulder of giants. We see one later, thanks to whom and his friends' pioneering work, we actually come up with a specialty for which we even in Switzerland and Europe even have a new specialization called the new heart failure doctor. As you know, we've done from Zurich, and so the future, it's been quite bright for a heart failure doctor. Thank you so much.